Welcome to the second meeting of the Violence Against Healthcare Workers Study Committee. I apologize for having to reschedule last week. It's a busy time right now and several other meetings conflicted, so it was necessary to change the date. I appreciate the committee's participation, and I'm happy that we're able to offer a Zoom option today. I think we do have two people on Zoom, Jennifer Spite and Kelsey Reed. I think that's it. Hi. Can you guys hear us okay on Zoom?
Yes, we can.
Okay, great. At our first meeting, we heard a lot of testimony from different stakeholders, and we know that violence against healthcare workers is not a new problem. In fact, there was a study committee on this in 2014. But we know that the problem has gotten worse and that COVID has aggravated the entire situation. Since the original study committee, some of their recommendations have been completed and others have not. Also, since that time, there's been a lot more media attention to violence against healthcare workers. And now JCAHO, the Joint Commission on Accreditation of Healthcare Organizations, if I got that right, is they have decided that they're putting in place new workplace violence prevention standards effective January 1st of 2022. And committee members, you have a copy of this. I think I emailed it to those of you who aren't here, but you have a copy in your folders also. And you also have a copy of a summary of the last meeting and the recommendations that were up for discussion. Since we last met, I've been working with GIPSTIC, the Public Safety Training Center, and NAMI, the National Association of Mental Health Georgia chapter, on options for a CIT type training program specific to healthcare workers. NAMI has a course that they teach that is 2 days, and GIPSTIC has a very robust training program for law enforcement, which is also accessible to hospital security personnel, as it turns out. That was one of the questions that came up at our last meeting. And as a result, NAMI, with help from GIPSTIC and Emory, has put together a draft of a one-day program that is a mixture of lecture and role play to cover de-escalation and self-care specifically for healthcare workers. The one-day format would eliminate overnight travel, and it also can be presented around the state, either at healthcare facilities or at the regional training centers for GIPSTIC. The cost per person, and this is just a draft and it's just up for discussion at this point, is somewhere between $100 and $120 per person. And hopefully this can serve as a good option for healthcare facilities that are working to comply with the new JCAHO standards for a reasonable cost. Regarding the recommendations, I'd like to walk through them with the committee before preparing the final report, keeping in mind that not all the recommendations have to be legislative. We've broken them down into 3 areas. First, proposed changes to the Georgia Code. Second, risk assessments and alerts. And third is training. So Alex Azarian, thank you so much for putting together a summary of our meeting and also boiling down the recommendations as something that we could digest. The proposed changes to the Georgia Code that came up in our conversation, the first one was to expand the enhanced penalties for aggravated assault and aggravated battery upon a healthcare worker to cover all healthcare workers within a healthcare facility. And we had testimony on this. The prosecuting attorneys council and the defense attorneys were against doing that. They felt that assault was already covered and that the definition of healthcare workers is tricky. And so we can discuss whether we agree with that or don't agree with it. And then creating a separate definition for healthcare workers, the advantage to that would be that right now we learn that under the current code, healthcare workers are covered, emergency responders and emergency department workers are covered under public safety as covered in the law. So there's no way to split that data out. And that is why we don't have good data on who's prosecuting things, and we don't have any good information on that. We don't know where that definition would start and stop. That's problematic in some ways. And then the third recommendation, and these are not necessarily things that will end up in our report, these are just things that came up in our conversation, would be to require mandatory reporting of aggravated assault and aggravated battery upon a healthcare worker, similar to mandatory reporting of gunshot victims or domestic violence victims. In other words, whether the victim wants to report or not. And we know that these assaults are underreported for various reasons. We heard that repeatedly from the healthcare facilities. For people view it as part of the job, or they're afraid of retaliation, or they don't really know what the avenue is to report. So mandatory reporting is something else that came up. We're not planning on having further testimony today, but we've got some knowledgeable people in the audience. And if you guys wanted to comment on anything, we can accommodate that. So just let me open it up for the committee members to see if you had any thoughts about that. My default is that legislation isn't always the answer, but we certainly want our healthcare personnel to understand that a lot of attention is being paid to this issue, and that we do hear their concern, and we really do want to make things better for them. The question is whether legislation is the way to get there or not. So any thoughts from the committee members? Bo, what microphone?
Number 5.
Okay.
So I want to start with the first proposed change, which is to enhance the penalties. And I've spoken with several healthcare workers who obviously would support this, but at the same time, they recognize that a lot of times the people that are committing these assaults probably don't necessarily waive the penalty when they commit them. So I would like to hear from someone if they, think making the penalties harsher would decrease the number of assaults, or if there's another avenue that we could come up with to maybe address the problem head on, whether it be training. I really like the idea of having training, and if we can help fund that or recommend to help fund that to the hospitals and to healthcare workers, I think that would be something that could be very beneficial. But I also, I went back and was watching the last meeting, and I know there was a common theme of the mental health side. It's overwhelming. The perpetrators that commit these acts are suffering from mental health issues. And I think that's a problem that we've got to try to wrap our minds around to see if there's anything we can do on that. But I would like to hear if, from someone, even anybody on the panel that thinks if making the penalties harsher would actually have an impact or not.
Let's see, we've got Jennifer and Kelsey. Did you want to weigh in at all? Either one of you?
Yes. This is Jennifer Spites, and I am a healthcare worker in a community mental health facility and have been for the last 17 years. I was very pleased to see, as a part of the recommendations, the emphasis on the training as well as the screenings. I do not agree in increasing the penalties, but I do stress the importance of the training for everyone involved as an intervention for this for the healthcare violence.
Thank you. Kelsey, did you want to comment?
And I have the same thoughts as Jennifer. I don't exactly agree with the enhanced penalties, but I think our focus should be more so on de-escalation training for our healthcare workers.
Thank you. I will add that I heard from the Alzheimer's Association subsequent to our last meeting, and they also were concerned because certainly our patients that are in the hospital, they're there for various reasons, and they can't we don't want them to attack our healthcare workers, but it's kind of gray how you handle that from a legal standpoint and from a law enforcement standpoint. Deb, did you want to say anything? You can come up here if you do. Or Anna, either one.
Madam Chairman and members of the committee, I'm Deb Bailey and I represent the Northeast Georgia Health System. And I think it was a number of our staff that generated this entire study committee. And I think COVID has certainly exacerbated what we're seeing in the hospital environment, and particularly with the violence against the healthcare workers. So it's several things have come to light during the study committee and in our own efforts within the hospital system to look and recognize that we've done a very poor job of helping our staff to understand that, that it is important to report these events. So it has been very much underreported. So it's certainly, I think that we recognize that now. And again, I think COVID, since it has exacerbated the number and the extent and the level of violence. However, when we look at the penalties, it doesn't really make sense, to be honest with you, that it's a misdemeanor in the emergency areas. And then when we get up to the med-surg area, that it's a felony in the emergency area. And then when we get up to the second floor and it's med-surg, it's a misdemeanor. That doesn't make sense to our staff. And whether or not now is the time to address that, I think it's certainly worthy of the conversation. And I do think as we look at reporting it more and looking at what numbers we're talking about and the level of violence and the perpetrator, are they psychiatric patients, we do know that many are, but we also know that many are not. So I do think it requires conversation because it is not logical to our nurses or to any of our clinical staff that are being assaulted that once we move that same patient up to the second floor, that the penalties are different.
Questions?
Well, I was going to see if somehow, and I'm just thinking out loud here, but I think it may be logical to make a distinction between a patient versus a family member or another member of the public that would maybe be trying to get into the hospital or something like that, and have a distinction in the code there. Because I do still think that, at least if my memory served me correctly, they said something like 90% of the assaults occurred from people with mental illness. Does that sound right?
No, I don't think we had. I don't think we honestly have a statistic on that.
What I read is that 73% of the assaults were from patients.
Okay. Yeah.
I'm not sure how accurate that is.
Yeah.
But I think that would be something. I mean, I think it's something to explore, definitely, because I think there's a huge difference between a patient and then a family member that may be trying to get in, or a domestic dispute trying to get to someone to keep them from talking or something like that. I would be in favor of having some clear lines in the law there, and maybe separating felony versus misdemeanor that way. But I mean, I'm happy to be on this committee, and I'm not a healthcare worker, and I'd love to hear from, thank you for coming. And we're always here to listen, and we want to do what's best for the healthcare workers in Georgia. Yeah.
And I think that, that's the thing they feel they have not before been heard. So this has been very helpful in the recognition that, that they're being heard and that this is a real problem.
Would you mind, while you're there, just commenting on the mandatory reporting suggestion that was made?
I think that we recognized through this process that we're not doing a good job reporting. However, I certainly can't speak for other hospitals, but for our system, I think it's going to be difficult because it's still going to be when you're reporting at what level. If you have, you do anesthesia, if the patient is coming out of anesthesia and frailing around, then is that something that has to be reported? So we start getting into that. I would like for that not to be included. I'd like for us to have an opportunity to, in the process of being able to do that a little better on our own without it being mandated.
Yeah.
One point related to the mandatory reporting. One thing that I thought about when looking at this mandatory reporting aspect, and I do think I agree with you that these incidents are underreported, but I worry about unintended consequences and I worry about the nature of the mandatory reporting. You know, we talk about it in the context of similar to gunshot victims or maybe like domestic violence, that type of mandatory reporting. What I wonder from a hospital standpoint is if we worry about those figures, how accessible they are to the public, whether it would be used for sort of hospital ranking data or public in that way, and the unintended consequence being that it discourages healthcare workers from engaging in high-risk patients, meaning patients with mental illness, that it actually dissuades people from providing the type of care that these patients might need because of this risk of maybe needing to mandatory report.
I agree. And I think if you recall in the testimony of the nurse from the Northeast Georgia Health System that was at our first meeting, I think of all the things that was most upsetting to her, it wasn't getting the heck beat out of her, ending up with a concussion and a post-concussion syndrome. It was the fact that once it was reported that patient knew where she lived, and her name, where she lived, and she had a 12-year-old son and a 16-year-old daughter that were home after school every day. And so that was the most concerning thing to her out of all of the entire event.
Yeah. So, and after talking to some of the attorneys about that, you know, that's a sort of a building block of our criminal justice system is facing your accuser. And so it can't be anonymous if you are press charges against somebody. And the hospital can't be the one to be the face for that very reason.
Yes.
So if what I'm hearing you say is it may be a potential safety risk for the healthcare workers if we were to implement a mandatory reporting type. And I think if that is, you know, and if that's the case, I think the public policy in Georgia, when you look at why we have mandatory reporting for domestic violence or abuse to children, gunshot victims, it's really to protect that person and help them get out of a situation that they may be in against their will. And I think this would actually go against the public policy of promoting safety if we were to require mandatory reporting.
And I think, to be honest with you, it's almost a cultural change within our hospital system of recognizing that that this is no longer business as usual. This has become an issue, and again, exacerbated by COVID. And we need our staff to report it to us. We need to know what those numbers are, what it looks like, and how we can keep our staff safer.
I also just wonder, one more thing procedurally is with mandatory reporting, how this would interface with the patient privacy issues.
Yeah. Thank you.
Yeah. So it's easy to write bills, but sometimes we are trying to fix something and we end up making it worse. So I'm getting the sense from everybody that's here that this might not be the way to address the problem.
I would agree.
And we do have a couple other things to talk about. So thank you very much.
Thank you. Thank you so much, each of you, for your attention to this.
And I'm going to go through this next part, and then I'd like to, Anna, if you wouldn't mind a little later in the discussion, commenting on how this would actually work for some of the hospitals that you represent, that would be good. First is encourage/mandate the use of behavioral emergency response teams, BERTs. We heard them referred to in the previous meeting. And Dr. Dave from Northeast Georgia could not be here today, but he said that he agreed with encourage, but didn't think it should be a mandate. And he had the same comment about the next recommendation, which was encourage/mandate risk assessments or screenings while patients are being processed. And I think we heard testimony about a tool that could be used, that could even be integrated into the electronic medical record as patients are being brought into the system. And then establishing an alert system for known violent patients came up. We get alerts on our electronic medical records on a lot of things, drug interactions, things like that. And the only thing I'll say about that is that there's a thing called alert fatigue. In this situation, you might not get that because it wouldn't be a everyday regular thing. But after a while, some of those alerts become ignored just because of people get tired of looking at them, I guess. But it's different than a medication interaction because it wouldn't be very common. It wouldn't be something that you see every day. So that's something to look at. And then the next three, the next two that were on there, I do believe are included in the JCAHO standards. One is to develop quality improvement initiatives to reduce incidents of workplace violence, including changes to the physical work environment, work practices, and administrative procedures. And then the other one was to require healthcare facilities to conduct periodic risk assessments and identify security risks within certain units. And I'm pretty sure that those last two are already in the thing that's happening in January of 2022. So, Anna, I don't know if you wanted to just comment on the assessment piece of it, screenings, alerts, and so on.
Thank you, Madam Chair, members of the committee. One of the things that, especially in our rural areas, we've had a lot of discussion about is what happens when one of our staff members is in a room and they are isolated and they have no way of escaping in a violent situation, especially now as we're thinking about all of the workforce challenges that we have. Some of these nurses may be seeing more patients than they're accustomed to seeing. And so patients are becoming more and more agitated with having to wait to see a nurse or even a care tech in their room. So one of the things that we have looked at from a vendor standpoint is a reporting device that could be attached to a nurse's badge to alert security system within the hospital that a nurse is experiencing an emergency with a violent patient in that patient's room. This is something that we are very interested in the technology of, and I think it could provide some peace of mind for some of these workers who maybe find themselves in areas of the hospital where there is a more frequent violent outburst tendency. Those are, of course, in some instances cost prohibitive. So that would be something that could potentially be a barrier to these types of programs being implemented. Additionally, depending upon how they work, some of these hospitals may not have the technology infrastructure to support that or the security means within their facility to address those issues. But I do think for some of the larger facilities, especially those that offer psych services, this is a viable option. And then the risk assessment and screenings at intake, I think this is an interesting idea, and it's something that we could certainly talk about. One concern that I might have about that is that sometimes those individuals who are doing patient intakes are not clinical. They are often, a front desk worker, somebody who comes around with a computer on the cart. And so they may not recognize the clinical signs of a patient who has violent tendencies. And it might be unfair for the facility to put them in that situation. It could potentially be a legal liability as well. So that's something that we would have to work through, but I don't think that it's a bad idea to kind of flag these people who are potential, who have a potential to be violent as they're coming into the facility.
That exact issue is the same thing you run into with defining what is a healthcare worker. if it's someone who has a badge that works in a hospital, they're a healthcare worker, but they may or may not be clinical. So yeah, that's
Absolutely.
the, what about so the alert system you were talking about would be a physical,
Yeah.
not a electronic notification in the record that someone had a track record?
So I haven't thought about the electronic notification in the patient record. That's something that we would have to look at from a legal standpoint. If that information is shared across patient records, I'm not really sure where that fits into some of the federal guidelines that we have regarding mental health. So we would have to check into that, and I can see if there are other states who do this as well.
I'm sure that because it's November and the new standards are being put in place in January, that you guys have already started preparing for how you're going to implement your programs to reduce workplace violence. Did you want to share any of that, or you guys sort of scrambling? Would you welcome a packaged up training program that could be delivered in a short period of time that you could take advantage of?
Yeah, I think that would be helpful. So many people don't know that GHA has an educational wing within our association. And so we are often providing educational opportunities on Joint Commission standards, conditions of participation, et cetera. So as these new processes and requirements are rolled out, we try our best to educate our membership. But anything that comes in a package is always very welcome and appreciated, especially for the smaller facilities.
Okay, great. Thank you
you
so much. Okay, so my sense is that encouraging the sort of best practices and things that have come up in other states or other healthcare facilities that were presented is a good idea, but mandating them at this point is not appropriate. Would anybody on the committee like to comment on that?
I would agree with that. I think the verbiage needs to be changed to encourage versus mandate. I did want to note that number 6, the establishing an alert system for nonviolent patients. I know there are many organizations across the country that already do this, but only a handful of people within that healthcare system are able to place those alerts in the chart. So I think that helps cut down on that alert fatigue that you mentioned. So we're truly identifying the patients that are more violent, more aggressive, and we're not just adding those flags to patients that don't necessarily need to have them.
Great, thank you. Other committee members?
Yeah, I was going to echo what she said earlier. I think instead of requiring, maybe, recommending or some verbiage like that. And if there are any resources we could put forth to aid in the training, especially at rural hospitals that may not have that type of training in place yet, or the resources to have the training, I would obviously be in favor of that.
Anybody else? One thing I forgot to mention that impacts this entire conversation is that the Behavioral Health Commission that was formed a few years ago, that did their first report, and they now have a draft bill that's a big bill about mental health. Big bills always have an interesting path from the legislature, but there is a robust conversation going on about mental health right now. And I have heard from both the governor's office and the speaker's office that they care about this issue. And so I predict this will be a big year to address mental health issues. And so I'm hoping that with the emphasis on that will come some resources. We'll have to see what happens. But so stay tuned for that Joint Behavioral Health Commission, I think is what it's called, for their bill. So let's talk a little bit about training. And there were 3 things that were recommended. One was require training for all members of the ER team, which should have been the hospital team, on interacting with behavioral health and potential violent patients. The second was to train all staff, including security and de-escalation and self-defense in response to emergency codes, security codes on hire and annually. And then the third one, which we actually have found out subsequently that that's already the case, is to allow state and local law enforcement agencies to partner with healthcare facilities and provide healthcare workers with the same training that law enforcement officers receive, such as de-escalation and crisis intervention and self-defense. But since the full CIT training has a lot of things in it that are not really pertinent to healthcare workers, they're very pertinent to law enforcement officers, that our hospital systems that have in-house security, not like some of our rural systems that one of my colleagues pointed out, might be the janitor being called to a room where there's a situation going on. So the resources vary greatly depending on whether it's a big hospital system or a small community hospital. But those healthcare public safety personnel, they already can participate in the training that's provided by JIPSTIC. And I'm not sure they all even know that, but that was clarified after our last meeting. So in terms of training, I think, again, the JCAHO recommendations are going to they're going to put a timeline on this, and we're going to have some tools. And so I'm sure there are going to be lots of sources for this type of training material. Some of it might be in-house, some of it might be through the NAMI JIPSTIC program that's being developed, some of it might be an outside vendor. But I think that's what happens a lot of times, is these standards get put in and then you just have to figure out how you're going to do it. So I think from my standpoint, training is a key part of what we need to be figuring out, and that might require some additional resources, but it probably doesn't require legislation to make that happen. That's already kind of in place at the federal level now with the JCAHO. Any other thoughts about training or anything that you think needs to happen with that? Do you agree with trying to get it to a one-day training? We know that with staffing, it's really hard to get people off the floor for long periods of time. And then you get into the whole overnight accommodations and all that thing if it's more than one day. So I think it's going to be a long day in this particular agenda that I gave to you guys. But I think that would be a tool that could be offered that the state could help with through agencies that already work in the space and also nonprofits that already work in the space. Any other suggestions about that? Yeah.
One other thing, in terms of the timing of this kind of training, I think this is a good start. In terms of it being annual, I wonder if something that's like biannual makes more sense, just to have it on the same schedule as how one has to do ACLS and BLS recertification, which is also usually an all-day type thing, that it puts it on that sort of schedule, because it is quite a bit, even if it is whittled down to just one day, that people take.
Well, the different requirements that are in here are annual worksite analysis, continual monitoring, which the hospitals do and a lot of other things. And there's something about reporting, quality improvement, and training. It says at time of hire, annually, and whenever changes occur. So they've already pretty much put that in place. So I think it's going to be a scramble to try to get all that done. And I think the key is to have a plan. Mm-hmm. And then to figure out how to implement the plan. So, but I'd love to hear any other comments from any other experts that are sitting in the audience, or any other committee members. I think our focus here looks like it's mostly training related, and then with some additional encouragement of developing these other resources about assessment and alert systems and things like that. But it sounds like the committee's not very interested in putting this in law. if I'm reading it right.
Can I just ask one question about I guess, recommendation number 11, which says allow state and local law enforcement agencies to partner with healthcare facilities? Is that something, did you say they can do that now? They can?
Yeah.
Oh, that's good.
Yeah.
Yeah.
They can access the robust training modules that they have at Chipstick, but I would have to say most of our hospital systems do have relationships already with their local law enforcement, and that is probably a bigger resource in smaller areas and systems that don't have their own security forces. But yeah, it looks like that's already in place. And sometimes we have things in place, but the word getting out is part of the process. So some of these tools, as they're developed, getting all the hospitals, getting the word out to all the hospitals, and the hospitals getting the word out to all of their people about what they offer, I think will be important. But that's not for us to legislate, I don't feel. Anybody want to add anything else? Seems pretty much like we're all on the same page here. So what we're going to do then is we'll come up with a report and send it around to the committee and get it ready, because our committee is designed to finish up before December 1st, which we could extend, but I don't think we're going to need to unless somebody disagrees. Okay, well, I want to thank the staff for your participation and help, and for helping us set our Zoom call up for people that didn't really want to travel here or couldn't travel here. And also thanks to the committee members, and we'll send you a report to vote on. Thank you. Meeting's adjourned.
Thank you.